Welcome. You're listening to the Keeping Ashland Healthy podcast, a podcast production of the Mental Health and Recovery Board of Ashland County, Ohio. Thanks for joining us. And welcome back to another episode of Keeping Ashland Healthy. This is David Ross, Executive Director here at the Ashland County Mental Health and Recovery Board. I hope you're staying warm. We are in one of those chilly seasons here in Ashland County, Ohio. But this episode is going to be hot. See what I did there? This one is about psychiatric diagnoses, which is, quite frankly, controversial in quite a few corners. The Mental Health and Recovery Board has published a document, Our Human Community, that I've referenced many times on the program. We have spotlighted the document in a lot of the work that we do. It's on our website. We've had conferences around it. Our upcoming RSVP conference will highlight dimensions from the document. But one of the things that has always energized me, even as a young therapist before I started even working at the board, was, our language, being precise with our language, understanding how influential language can be. I'll never forget I'm geeking out a little bit here, but one of my favorite authors when I was younger as a clinician was Mr. Steve DeShazer. And Steve wrote a book towards the end of his career in life, actually, because he passed away fairly young, called Words Were Originally Magic. Check that book out if you haven't. But again, when we think about the words that we use in historically, how incredible and what words have done to shape relationships in our societies and what we've been able to achieve and accomplish through effective communication. The idea of psychiatric diagnoses, these so-called medical labels, if you will, have fascinated me because what I've seen them do to the individuals that receive them. And that's what's so critical. What I have seen over the years, particularly when I was doing direct services, how folks can over-identify with a particular label, diagnoses, and how, particularly in younger folks, that can actually become the identity. Folks start referring to themselves as their diagnosis rather than them viewing the diagnosis as just a label or a helpful construct, if you will, of what might be going on for them. So today's episode, again, if you find yourself disagreeing with me, you're in good company. Nobody agrees with me. But I'd ask you to be patient and at least consider maybe some of the things I'm saying, because I'm actually not alone in this. A lot of the content that I'll be talking about has been around 30, 40 years now. This is not new stuff, but I'm always looking for new folks that are saying it, maybe saying it in a slightly different way. Certainly, we did not have social media the way we do now back when a lot of this was first being talked about, written about, et cetera. So there's a whole new generation of individuals that maybe have not heard some of the challenges that come with a psychiatric diagnosis. So Jonathan Shedler is a PhD. I'll link to a piece that he did that I drew a little bit from. But again, in fairness, the points that Dr. Shedler's making have been around for a long time. So his piece, A Psychiatric Diagnosis is Not a Disease, Why Language, Science, and Humanity Matter. I'll pepper in throughout this episode some pieces from that work that he did. And again, I'll credit him and the work in the episode description. But so let me start with a simple but important claim. Okay, a psychiatric diagnosis is not a disease. Okay, a psychiatric diagnosis is not a disease. So let's start there and consider that. That may sound strange, even controversial, depending on where you're coming from. After all, for decades, we've been told that conditions like depression or anxiety or ADHD, that they're illnesses, much like diabetes maybe or pneumonia, something caused by biological problems. And oftentimes we've heard that expression, they're chemical imbalances in the brain. But that story is just not supported by the evidence. And more importantly, it misunderstands what psychiatric diagnoses actually are. So today I want to walk through an argument made by psychologist Jonathan Shedler and connect it with a growing body of thinking that really just challenges how we talk about mental health, distress, and recovery, especially here in Ashland, Ohio, in our Ashland community. So what psychiatric diagnoses really are. The DSM, the Diagnostic and Statistical Manual of Mental Disorders, is often treated, and you'll hear it called this, the Bible of psychiatry. But the DSM, this manual of mental disorders, doesn't really identify diseases in the way medicine usually does. And in fairness to Alan Francis, who was the chairperson of the DSM-4, I think he put something in the forward there that says that they're actually constructs, not diseases, but quite frankly, most folks know them as diseases rather than constructs. Instead, the DSM diagnoses are, it's best to think of them as descriptive labels. They describe clusters of experiences and behaviors that tend to occur together. So, such as persistent sadness, anxiety, loss of interest, sleep problems, difficulty concentrating. When we say someone has, for example, major depressive disorder or generalized anxiety disorder, what we mean by that is we're naming a pattern of a variety of things, not identifying a cause. Okay. And this is where the confusion creeps in. We start to talk as if the diagnosis explains the problem. Okay. So it goes like this. Why is this person anxious? Well, because they have anxiety disorder. Why are they depressed? Because they have depression. Do you understand the problem with that? That's what we call circular logic. It's like saying someone is sad because they have sadness disorder. Okay. So the diagnosis does not cause the experience. Okay. All it does is describe it. And that's important. So that's point one. Two, why this is different from a genuine medical disease. Okay. In medicine, typically what you'll find is the diagnoses, they usually point to some kind of underlying cause or causes. So for example, maybe chest pain. Okay. That's a symptom. You're experiencing chest pain. I've experienced chest pain myself. It's a symptom. What's a symptom of? Maybe it's pneumonia. Maybe you're having a heart attack. Blood clot might be the disease that's causing it. So psychiatric diagnoses, they don't work that way. Okay. They're not tied to a single biological mechanism. They don't map onto a clear disease process. Okay. They don't predict cause, course, or response to treatment the way medical diseases do. And again, in fairness, even the American Psychiatric Association has acknowledged this directly. People with the same diagnosis might have very different underlying causes and may respond to very different treatments. When we talk about psychiatric diagnoses as if they were diseases, we are making what we call a category error. We are treating a label, a descriptive label, as if it were a biological explanation. Okay, pause, get some coffee, think about that, okay? So when we talk about psychiatric diagnoses as if they were diseases, we are making a category error, okay? This is a kind of thinking error, logic error. We are treating a descriptive label as if it were a biological explanation, okay? Don't do that, all right? The chemical imbalance story. This confusion has been reinforced by one of the most persistent myths in mental health, the idea that conditions like depression are caused by chemical imbalances. Now, again, this theory has been thoroughly debunked, and I don't think you can get a reputable doctor to say that's not the case, okay? But for many, many years, there has been a lot of effort made in advertising, pharmaceutical ads, and other places to convince folks that there is a chemical imbalance, and that is what's causing things. So you can understand why the general public would be confused. There's no reliable evidence that low serotonin causes depression, for example, in the way that low insulin causes diabetes. Most folks now, like I say, acknowledge that, but that language is still out there. And I'm sorry for the folks that push back and say, oh, nobody believes that anymore.
I talk to folks all the time that are not experts. They're not clinicians. They're not counselors and social workers and psychologists and psychiatrists. They really do believe that. Advertisers still kind of imply it. Insurance policies, public messaging, it's still out there, even if it's not as direct as it used to be. It's really not too hard to see how they're still implying it. So why does that matter? It matters a lot because when we frame human distress as a broken brain, we quietly remove meaning, from people's stories. And this is why I get so jazzed up about this, because I really believe in the importance of our stories. So when we frame distress as like a broken brain, we are removing meaning from people's stories, their relationship, their losses, the pressures and circumstances, Biology matters, but biology alone does not explain human suffering, I'll say that again. Biology, in fact, matters, but biology alone does not explain human suffering, So a more human way of understanding distress. If diagnoses aren't diseases, how should we think about mental health struggles? Because I'll be the first to tell you that we all struggle. A better framing is this. Try this one on. A better framing is this. People are experiencing mental and emotional distress, That distress arises in context. It arises in the context of relationships, of trauma, of loneliness, maybe lack of purpose, which we've talked about, economic pressures, identity issues, meaning, lack of meaning. We talked about that in a previous episode. Two people can look identical on a checklist and be suffering from completely different reasons. When we were focusing on adverse childhood experiences, ACEs and resiliency, we discussed this. This is where two different people might experience very similar trauma, but one individual might be incredibly resilient because they maybe have that caring, loving adult in their life that helped mitigate those challenges, those traumas. So again, context is so crucial. So that's why, this whole one-size-fits-all treatment model, that really bothers me. Each person's situation is unique. Their context of what they're going through is unique. The one-size-fits-all models, they just always fall short for me. Now, and I'm not saying I'll make mention of medication. We do that in our human community document. It's not to say no medication ever, but it does mean therapy is complex. And if medications are going to be used, there needs to be a lot of informed consent and full disclosure to the individual. In general, it should not be given first as a front line. If used, it should be used at the lowest dose that is effective, and it should be used for the shortest amount of time. And we should avoid multi-medications at the same time, sometimes called polypharmacy. So again, it's not a never medication, but boy, oh boy, we need to be putting everything else first rather than jumping there to the medication the way we have been the last 30 years. It means we should stop confusing labels with explanations. And start taking people seriously as whole human beings. I mean, just because we can throw a label on something doesn't mean we understand it. I hope you understand that. Just in a general, everyday context, labeling something doesn't explain it. Those are two totally different things. Why this matters for Ashland County. I want to bring this home. This conversation isn't academic. I know it sounds academic. It affects how services are designed. This is why the board's embracing of our human community document and integrating within our mission, vision, and values, and partnering with our contract agencies. In fact, requiring our contract agencies to be on board with this has been critical for Ashland County because it does affect how the services are designed, how care is funded, how it's delivered, how the people in our community understand themselves. When we reduce distress to diagnoses, we really risk over-medicalizing normal human pain. I'll say that again. When we reduce distress to diagnoses, we risk over-medicalizing normal human pain, and we ignore social relational drivers, and we silence, really, people's stories, So that's why this matters. A more honest approach doesn't reject science. It demands better science and deeper humanity, to be honest. The perspective aligns with how we think about mental health and recovery here in Ashland County. It aligns with our focus on supporting people, families, communities, not just treating symptoms. So I'm getting to that point. I know 15 minutes. Folks have other things they have to do. So just let me say in closing, Jonathan Shedler's core insight in his piece was simple but powerful. Psychiatric diagnoses are tools for description, not explanations of disease. When we remember that, we regain something essential. I think we gain curiosity, humility, and respect for the complexity of human lives. And boy, oh boy, that's what you should be looking for if you're going in to get services. You're going to be talking to a therapist. And if you're a counselor, social worker coming up, I want to just stoke that in you. Stay curious, stay humble, respect the fact that human beings are immensely complex. Mental health work is not about fixing broken brains. It's about walking with people through distress toward meaning, connection, and hope. And that shift, ladies and gentlemen, that changes everything.
Thank you for listening to another episode of the Keeping Ashland Healthy podcast. The podcast is a production of the Mental Health and Recovery Board of Ashland County, Ohio. You can reach the board by calling 419-281-3139. Please remember that the board funds a local 24/7 crisis line through Appleseed Community Mental Health Center. It can be reached by calling 419-289-6111. That's 419-289-6111. Until next time, please join us in Keeping Ashland Healthy.